Today we are going to discuss aortic stenosis. The aortic valve is a semilunar valve which is placed between the left ventricle and the ascending aorta. So this valve directs the flow of blood in the left ventricular outflow tract. Now there are three types of problems in the left ventricular outflow tract which cause obstruction. One of them is valvular stenosis, the other ones are subvalvular or supravalvular stenosis. That is, the stenosis may be lying below the aortic valve or it may be lying above the aortic valve. But today we are going to discuss the problems of aortic stenosis, that is, the problem of the aortic valve itself. Now, when we see what are the causes of aortic valve stenosis, mainly there are three types. One is congenital type of stenosis, then second is the post-inflammatory type of stenosis, and the third one is degenerative stenosis. And if we divide the patient population who have got aortic stenosis in two segments, that is the patients who are less than 70 years old and the patients who are more than 70 years old. In patients who are less than 70-year-old, congenital bicuspid aortic valve is more important. Aortic valve is normally a tricuspid valve. It has three cusps. In some patients, they have a congenital abnormality when they have only two valves, and these valves, they tend to become stenotic as the age passes by. So patients who are less than 70 years old, majority of them are suffering from a bicuspid aortic valve. Then almost 1/4 of them are suffering from post-inflammatory aortic stenosis, for example, post-rheumatic fever, or after other inflammatory conditions like certain connective tissue disorders like ankylosing spondylitis. Then 18% have degenerative disorders, and a small proportion has a unicommissural valve or a hypoplastic valve, or 2% have indeterminate cause for the aortic valve stenosis. And similarly, if we go for the patients who are beyond the age of 70 years, we see more patients are suffering from degenerative disorders. So younger patients are suffering from congenital type of disorders, while the older patients are suffering from degenerative type of disorders. So 48% of the patient above the age of 70 years have degenerative aortic stenosis. Then 27% have bicuspid stenosis, and another 23% have post-inflammatory aortic stenosis, and then a small percentage may be having hypoplastic aortic stenosis. So you can see in patients who are younger than 70 years, it is the congenital type of aortic stenosis which is more common, and patients who are more than 70 years old, in them degenerative type of aortic stenosis is more common, and in between is the post-inflammatory aortic stenosis. Now, when we see the statistics, we see patients who are more than 75 years old, almost 2 to 9% are suffering from aortic stenosis, depending upon the different studies and different populations. And you see, aortic stenosis is relatively more common in males than in females. And as we discussed, there are three main types: the congenital, the post-inflammatory, and then degenerative type of aortic stenosis. You see, congenital type of aortic stenosis is present in 0.33% of live births. They may be suffering from a unicuspid valve or a bicuspid aortic valve. The symptoms, they usually start in middle to late age groups. Then rheumatic aortic stenosis, the symptoms usually start after the 6th decade, although the process starts in the childhood. And patients who've got aortic sclerosis, they are usually older patient. And you see, at the age of 65, almost 29% of the adult population has some degree of aortic stenosis. And at the age of 75 years, this figure increases to 37% of the population. Now we see a little bit of pathophysiology. What happens when there is aortic stenosis? You see, when the valve area is decreased, this is stenosed. This becomes tighter. So the left ventricle has to eject against a high pressure. So it means there is increase in left ventricular systolic pressure. The left ventricular systolic pressure rises to overcome the resistance caused by the narrowed valve. So what is the consequence of this persistent left ventricular systolic pressure increase? The left ventricle starts hypertrophying. You see, this is hypertrophy, and this is usually a concentric hypertrophy. This similar hypertrophy is seen in patients who are suffering from uncontrolled chronic elevated hypertension, Otherwise, patients who have got subaortic stenosis, they tend to have asymmetrical type of hypertrophy, that there may be a septal hypertrophy, or only there may be asymmetrical hypertrophy around the outflow tract. But patients who've got aortic stenosis, they have concentric left ventricular hypertrophy. Now, what is the consequence of this left ventricular hypertrophy? You see, when the muscle hypertrophies, it becomes stiff. The contraction of the heart is energy dependent, as well as relaxation is energy dependent. It is not like what we see in the lungs. The inspiration is energy dependent process. The inspiratory muscle, they contract and the lung expands, and the inspiratory muscles, they relax, the lung collapses back because of the elastic recoil of the lungs. This does not happen in heart. The heart contracts actively and relaxes actively. When there is hypertrophy, this relaxation becomes a problem. So the relaxation is seen in diastole. So in these patients, the end diastolic pressure also starts increasing. So not only the systolic pressure rises, but as the time passes, the end diastolic pressure also starts rising. What is the consequence of this rise in left ventricular end diastolic pressure? You see, the atria, they push the blood in diastole. So they cause flow of blood from the atrium into the ventricle is seen during the ventricular diastole. Since there is a high pressure in the ventricular diastole, the atria have to exert more pressure to push the blood into the left ventricles. So the result will be the atrial pressure will also start rising. So the left atrial pressure starts rising. Now, since there is no valve between the left atrium and the pulmonary veins, this pressure is transmitted backward from the pulmonary veins ultimately into the pulmonary capillaries. So pulmonary capillary pressure starts rising. What is the consequence of this rising pulmonary capillary pressure? You see, when the patient exerts, there is increased demand. The heart starts contracting more forcefully, and this pressure rises further. This can result in transudation of fluid into the interstitial spaces. That causes decrease in the lung compliance, and the work of breathing is increased. So the patient starts having shortness of breath. So this is because the left atrial pressures are rising because there is increased left ventricular and diastolic pressure. Then as the time passes, there is declining contractility. This again contributes to further problems of aortic stenosis. This declining contractility results in diminished cardiac output. And because of these two problems, that the patient has problems now in systolic contraction and in the diastolic relaxation, patient starts having symptoms because of the aortic stenosis. So this is a very long time. There's a long latent period after which the patient starts developing these symptoms. Now, what are these symptoms? Patient has exertional dyspnea, as I already discussed. When the patient exerts, there is elevation of the pulmonary capillary pressure, which is because of the reduced compliance of the left ventricle, and there is also failure of the left ventricle to eject large amount of blood. The cardiac output decreases, and the left ventricle also starts dilating. Not only it starts hypertrophying, it starts dilating. So both result in a rise in left ventricular end diastolic pressure. This end diastolic pressure then is transmitted to the atria and then back into the pulmonary circuit. So the pulmonary compliance starts falling, and patient starts feeling shortness of breath on exertion. Then the patient may have exertional angina. Patients usually do not have angina at rest, but it's usually with exertion because there is an imbalance between the oxygen supply and demand. The cardiac output in aortic stenosis is usually fixed. It cannot be increased very much. There is only a small fraction which can be increased if the stenosis is not very tight. But since this is a hypertrophied muscle, its oxygen requirements are generally higher than when the patient does not have aortic stenosis. And when there is exercise, this increasing demand cannot be met by the fixed cardiac output. So the patient starts having symptoms of angina, even if the coronary arteries may be normal. So this is one condition in which with the normal coronary arteries, patient can have symptoms of angina. Similarly, patients who've got severe anemia, they sometimes can have symptoms of angina despite having normal coronary arteries. Then the patient may have exertional syncope. Syncope may also be induced by nitroglycerin. Patients usually have ventricular tachycardia, atrial fibrillation, or different type of conduction blocks that can result in hypotension. And when there is increased demand by the exercising muscle, since we know that cardiac output is fixed, it cannot be increased. The muscle who are exercising, they need more blood. So the blood is diverted towards those exercising muscle, and less of the cardiac output goes into the central nervous system. So the result is there is ischemia of the central nervous system, and patients tend to have syncope. Similarly, if you give nitroglycerin, what nitroglycerin causes vasodilatation. Not only it decreases the venous return, it causes arteriolar dilatation. So the blood goes into those dilated arterioles, and the CNS is deprived of that blood. So the patient, they tend to develop syncopal attacks. So these are the main symptoms these patients have. And then there are certain other manifestations. For example, patient who got bicuspid aortic valve. This valve tends to be associated with aortic root dilatation. So there is not only bicuspid aortic stenosis, there is dilatation of the aortic root, and this can result in aortic dissection. So this patient can present with aortic dissection. The patient may have severe sudden onset chest pain which goes to the neck, and sometimes it can go into the back and into the arms as well if the dissection is proceeding into the subclavian arteries. Then patient may have infective endocarditis. They may present with vague symptoms like low fever, fatigue, anorexia, and weight loss. Then calcific aortic stenosis. It is associated with emboli of calcium to various organs. The emboli can go to the heart, to the brain, to the kidney, and cause problem in those relevant organs. Then there is a Hyde syndrome, which is because of the bleeding from the GI tract, as there are angiodysplasias formed. These angiodysplasias, they generally disappear after the surgery. Then physical examination. So more important is we examine the pulse. The pulse is characteristic for aortic stenosis. There is a delayed peak and a plateau, and there is decreased amplitude and gradual downslope. This is called parvus et tardus pulse, slow rising pulse. So you can see this is the normal shape of the pulse. There's an upstroke, there's a sharp peak, and there's a downstroke. While in aortic stenosis, we have got a slow upward peak, then the peak is not sharp, this is plateaued, and there is a gradual downslope. So we get this sort of pulse in aortic stenosis. This is called parvus et tardus. Patients who develop heart failure, they develop pulsus alternans. That is, there is a strong pulse and there is a weak pulse. The strong and weak pulses, they alternate. So that is why it is called pulsus alternans. And now the question, where should this pulse be examined? As we go down the arterial tree, the characters of the pulse starts fading. So it is better that this character be examined at the carotid artery. So we examine the carotid artery for the character of the pulse, which is parvus et tardus. And then we come to the examination of the precordium. Precordium may show a palpable left ventricular heave. There is a sustained left ventricular heave, and there sometimes may be a systolic thrill as well. The second heart sound, the aortic component is weak or it may be absent. And then there is a reverse splitting of the second heart sound in severe aortic stenosis because of the prolonged ejection time. Now we see this is normal heart sound. This is first heart sound and this is second heart sound. What happens? In inspiration, since there is a negative intrathoracic pressure, there is increased venous return to the right side of the heart, the ejection of the right heart is delayed. So the second heart sound moves slightly away from the aortic component. So the pulmonary component that moves away from the aortic component, and we have a split second heart sound, which is a normal phenomena. That is, the second heart sound is heard as one sound in expiration and a double sound in inspiration. But what happens in aortic stenosis? The ejection time of the left ventricle is increased. Therefore, the left ventricle takes longer time to stop, and the aortic component of the second heart sound is delayed as compared to what we see normally. So these two sounds, they separate in expiration, while in inspiration there is no effect on this phenomena. So we have a splitting of the second heart sound in expiration rather than the normal we hear in inspiration. So this is called reverse or paradoxical splitting of the second heart sound. So we may see a reverse splitting of the second heart sound, and we sometimes may be able to hear the S4, that is the fourth heart sound. It reflects that the atria are contributing to the filling of left ventricle against high pressure. Then we come to the murmur. We have got a systolic ejection murmur that is rough, that is low pitch, that is crescendo decrescendo, that it's a kite shaped murmur. It is best heard at the right second intercostal space alongside of the sternum. This is called aortic 1 area, and this murmur may radiate to the neck, and in milder cases this may also radiate to the apex as well. Now, what are the characteristics of this feature? We see this murmur is a systolic murmur. It's an ejection murmur. This is a crescendo decrescendo murmur, and it increases on squatting, and it also increases on a premature beat. When there is a ventricular premature beat, there is a compensatory pause which follows the ventricular premature beat. So what is the consequence of this? That there is a long time for ventricular filling available. Ventricular filling is in diastole. When there is a premature contraction, there is a compensatory pause, and the next impulse comes late. So there is enough time for left ventricle to fill, and the left ventricle contract forcefully. That's why the murmur is increased. Similarly, patients who've got atrial fibrillation and those who have got long RR interval, that is, two beats are separated by a wider distance, the murmur increases. Similarly, it decreases during the straining phase of Valsalva, and in patients who've got atrial fibrillation and if they have got shorter RR interval, in that period the murmur will decrease. Now, the duration of the murmur gives us some idea of the severity of the aortic stenosis. You see, the severer the aortic stenosis, the longer is the duration of the murmur. Now we see this is the systolic phase of cardiac cycle. And you see, if there is a less tight stenosis, large amount of blood is ejected in the early part of cardiac output. So you will hear a murmur in this period. But as the stenosis becomes tighter, the murmur starts increasing in duration. So longer the duration, the severer stenosis. And then there is a second phenomena. We see here that we see the peak of the murmur. And as the stenosis becomes more and more severe, this peak is shifted thisward towards the later part of the systolic phase. So if we get a peak in the later part of the systolic phase of cardiac cycle, the aortic stenosis is more severe. So what we see, we can assess from the duration and the peak of the murmur how severe the aortic stenosis is. But clinically this is a little more difficult because these patients, they tend to have tachycardia, and it's difficult to assess in patients who've got failure or atrial fibrillation, all this. So for that purpose, we grade the aortic stenosis on echocardiographic finding. But the clinical feature is that as the murmur duration increases and the peak shifts towards later part of the systole, this is more severe aortic stenosis. In less severe aortic stenosis, the murmur is heard in the early part of the systole, and the peak is also towards the early part of the systole. Then other features, patient may have associated aortic regurgitation, and there may be murmur of aortic regurgitation there. Patient may have right ventricular failure. Features of right ventricular failure. The right ventricle may not fail, but there are features of right ventricular failure, that is systemic congestion. Now what happens when there is hypertrophy of this left chamber and there is a high pressure? This shifts the septum towards right ventricle. So that results in impaired filling of the right ventricle. So when there is impaired filling, there is diminished output from the right side. So there is backward systemic congestion. You see the blood is not being able to flow here. So the pressure starts rising in this area. That results in pressure in the inferior vena cava. When there is pressure in the inferior vena cava increases, you have systemic congestion. The congestion may be manifested by dependent edema, hepatomegaly, the JVP may be elevated, and there may be a prominent A wave because the atria has to push against this resistance caused by the shifting of the ventricle septum towards the right ventricle. This is called Bernheim effect. Now, what's the differential diagnosis? The differential diagnosis includes acute coronary syndrome if the patient presents with exertional chest pain. Patient murmur has to be differentiated from the murmur of mitral regurgitation. Sometimes the mitral stenosis has to be kept in differential diagnosis because the pulse is weak in both mitral stenosis and aortic stenosis. Mitral valve prolapse, and then if the patient presents with hypotension, hypovolemic shock is one of the differential diagnoses. So this is the differential diagnosis of aortic stenosis. Now, what investigations we do? We go for routine blood tests. They are required to assess the presence of anemia because anemia can worsen the features of aortic stenosis. If the patient has endocarditis, there may be leukocytosis, the ESR may be high. You can send the blood cultures, check for serum electrolytes and serum cardiac biomarkers, that is like CPK or cardiac troponins, to rule out acute coronary syndrome. Then another important test is serial pro-BNP, that is pro-brain natriuretic peptide, in asymptomatic patients who've got severe aortic stenosis, because serial testing of pro-BNP, if the pro-BNP starts rising, that tells us that this patient will benefit from surgery and this patient will require surgery. So if we take pro-BNP and then measure it after 6 months, and if this is increased, that means the disease is progressing and the patient may be requiring surgery. And then we got definitive tests like imaging. We may have ECG and Holter monitoring, chest X-ray, echocardiography, dobutamine echo, and cardiac catheterization. So we need these imaging studies to evaluate the aortic stenosis. Now, ECG, 85% more patients show left ventricular hypertrophy. How do we check left ventricular hypertrophy? We use the voltage criteria. We take the chest lead V1 and V5 or V6. We add up the negative wave in V1 and the positive wave in V5 or V6. If this is more than 35 millimeters, this is voltage criteria for left ventricular hypertrophy. This particular ECG shows a sum of 40 millimeter, which means this patient has left ventricular hypertrophy. In addition to the left ventricular hypertrophy, we can see left atrial enlargement because of high pressure in the left atrium. We may see left axis deviation. We may see left bundle branch flock. There may be atrial fibrillation. Patient may have atrioventricular blocks, first degree, second degree, or third degree or blocks. Then if patient has palpitations, we can go for Holter recording, that is ambulatory ECG recording, and we can see what type of arrhythmias are there. We may find ventricular ectopics, they may find ventricular tachycardias, or we may find atrial fibrillation on Holter recording. And then chest X-ray. Chest X-ray is not a very useful investigation in initial part of the aortic stenosis disease. As the aortic stenosis becomes chronic and severe, we find some changes on the X-ray. For example, the heart, which may be normal in size, because initially the hypertrophy is at the lumen of the expanse. The heart does not dilate, but the lumen becomes narrow. So the radiological shadow remains normal. As the heart starts dilating, then you may have a larger shadow. The cardiac silhouette shows rounding of the borders and the apex. You can see this rounding of the apex and border. You may see dilatation of the aorta. There may be calcification of the aorta, there may be dilatation of the aorta. And then in the lateral view, sometimes we can see calcification of the aortic valve in degenerative aortic valve disease. There may be enlargement of the left atrium, pulmonary artery, and right ventricle in cases of severe aortic stenosis. Then the most important investigation, the echocardiography. This is the most important investigation when we are assessing the valvular lesions. So we can go for a transthoracic echo or we can go for a transesophageal echo. Usually first we go for a transthoracic echo. And from the transthoracic echo, we can see the severity of the aortic stenosis. We can see the associated aortic regurgitation and how severe is the aortic regurgitation. We can see the left ventricular size. We can assess the hypertrophy. We can assess the diastolic dysfunction. We can assess the systolic dysfunction. So we can assess all on this transthoracic echo. Then you can also assess the estimation of pulmonary systolic pressure, and if there are any other cardiac abnormalities associated. For example, if the patient may have mitral valve disease, so you can see all on transthoracic echocardiography. And in some patients, when we need more information, for example, if the patient has endocarditis and vegetations are not visible on transthoracic echo, we can go for a transesophageal echo, and this can see the aortic valve more closely and gives us a better idea of the aortic valve cross-sectional area, the valve structure, and the vegetations if there are any. Then we can go for stress testing. Keep in mind, patients who've got severe aortic stenosis and are symptomatic, exercise testing is contraindicated. So patient who've got severe stenosis, they have symptomatic aortic stenosis, exercise testing should not be done. Exercise testing helps us in asymptomatic patients to assess the capability of patient regarding how much exercise they can do, what is their exercise capacity. And then we can go for dibutamine echo. Dibutamine echo, we do it in moderate aortic stenosis and LV dysfunction to assess the reversibility of the LV function after we go for aortic valve replacement. So it can be done prior to planning surgery, that how much will be the benefit from the surgery. So this gives us the information about how useful is going to be our surgical management. Then cardiac catheterization. Cardiac catheterization is not routinely done. If there is discrepancy between the clinical features and the echocardiographic features, one can go for cardiac catheterization. Similarly, young patients who've got congenital non-calcific type of aortic stenosis, in those patients, we can assess the severity of the aortic stenosis on catheterization. On catheterization, we can differentiate between valvular, supravalvular, and subvalvular type of stenosis. And patients who've got a suspicion of underlying abnormal coronaries, we can go for coronary angiography at the same time. So these are the indication of cardiac catheterization. And then we've got investigational imaging modalities like cardiac MRI or cardiac multi-slice CT scan. They are upcoming investigations and they may be useful in some circumstances, but they are not routinely done to assess the aortic valve stenosis. Now, grading of the stenosis. This is important. We grade the aortic stenosis on echocardiographic finding. We use two parameters. Number one is the cross-sectional area. Cross-sectional area of the aortic valve. And the second parameter is the mean gradient, pressure gradient. Across the aortic valve. So it is divided into four different types: mild, moderate, severe, and critical. Depending upon these two, patients who got mild stenosis, their cross-sectional area is more than 1.5 centimeters square and the mean pressure gradient is less than 25 millimeters. Patients who got moderate stenosis, their cross-sectional area is 1.1 to 1.5 centimeters squares and the mean gradient is between 25 and 40 millimeters of mercury. Patients who got severe aortic stenosis, the cross-sectional area of the valve is 0.75 to 1 centimeter square and the mean pressure gradient is more than 40 millimeters of mercury. Patients who got critical stenosis, the cross-sectional area is very tight and the mean pressure gradient is more than 80 millimeters of mercury. Medical management. There is no role of medical management in aortic stenosis itself. Now, what we can do, we see if the patient is hypertensive, the blood pressure should be reduced to normal levels. Avoid trying hypotension, that causes devastation in these patients. Patients who've got heart failure and those who are not candidate for surgery, we can go for conservative medical management, like patient can be put on digoxin, diuretics, and vasodilators like ACE inhibitors or ARBs. Similarly, the patient who complain of angina, beta blockers can be used to control the angina. Endocarditis prophylaxis is not routinely recommended in patients who've got aortic stenosis. Then surgical treatment. One is percutaneous balloon valvuloplasty. We put in a balloon through the arteries into the aorta, and then we can dilate this aortic valve with balloon. So this is not a definitive treatment. This is usually done in certain circumstances. Now, what are the patients we go for balloon dilatations? Patients who refuse surgery, we can go for balloon dilatation. Similarly, patients who've got short life expectancy and they have comorbid conditions, for example, patient may be having some malignancy or patient may have some other debilitating illness. In these patients, we go for balloon valvuloplasty rather than we going for surgery. Patients with heart failure who require surgery for some other condition, for example, if the patient has developed intestinal obstruction, patient requires urgent surgery. In that case, we can go for balloon valvuloplasty. Similarly, pregnant patients who got critical stenosis, they can go for balloon valvuloplasty. Now, what is the advantage of this balloon dilatation? That you get immediate result. You see, best results are seen in commissural bicuspid aortic valve, almost 60 to 70% of gradient reduction immediately. What are the problem with balloon dilatation is that re-stenosis is high. At 6 months, almost 60% are having stenosis, and at 2 years, almost 100% have re-stenosis. So they need to be redilated. And when you dilate 10% of the patient, they have the risk of developing aortic regurgitation. The treatment of choice is valve replacement. The valve replacement can be transarterial, it can be an open cardiac surgery. In open surgery, there is an advantage if the patient has abnormal coronary arteries, CABG can be offered at the same time. That is, we can go for coronary artery bypass grafting as well. So we can go for transarterial valve replacement or open valve replacement. Now, what sort of the valve to be used? Bioprosthetic valve versus mechanical valve. You see, bioprosthetic valves, they have a problem. There are more valve failures and there is frequent requirement for bioprosthesis, while mechanical valve, they need to have a stringent anticoagulation. The rates of survival, thromboembolism, bleeding, endocarditis, and major adverse prosthesis related events are similar in both groups. So the advantage is that with bioprosthetic valves, we don't need a very stringent anticoagulation. Now, patients who undergo surgery, operative mortality is less than 5% if the systolic function was normal before surgery was started. But patients who've got abnormal ventricular function, they tend to have higher mortality. For example, patients who are in NYHA class 4, they tend to have 25 to 30% mortality with valve surgery. If the patient has preoperative LV dysfunction, patients who are old and patients who have got associated aortic regurgitation tend to have more complications. So this is about aortic stenosis. Next time we are going to discuss aortic regurgitation. Till then, we close our discussion here.